Hi, my name is Lionel Bouchet. I'm with Mevion Medical Systems. I'm the Senior Vice President of Commercial Development. I'm here today with Dr. Maity, Chair of the Huntsman Cancer Institute Radiation Oncology. Hi, Dr. Maity. Thank you for being with me.
Thank you very much for having me.
Dr. Maity, you just joined about a year ago here as chairman. Congratulations first on joining. How has been the transition?
Been wonderful. It's Utah is a great place. Salt Lake City, as you've seen, we're located on the side of the mountain. So the center itself, it's just a spectacular place to be. But probably more importantly, the people here are great. I've really enjoyed getting to know all the folks in the department, including the physicists, as well as the physicians, but also all the staff. There's a real sense of, we have a mission to treat patients. The Huntsman Cancer Center is the only NCCN comprehensive cancer center within 5 states. So it's not just the state of Utah, but it's also Montana, Idaho, Wyoming, and Nevada. So we get patients from all over these 5 states with cancers. And there are certain things that, you really can't do at, centers that are not, as comprehensive as a place like Huntsman. One of them is what we're talking about today, which is proton therapy. That's something that they got up 2 years ago, and it's a huge resource. There are patients that previously we would be seeing in consultation and be referring to Seattle or San Diego that for proton therapy, that we now can say we have this and we can really offer you state-of-the-art treatment for your cancer. So it's been a great transition.
Great. So you come from University of Pennsylvania, where you already had proton therapy, and you're coming here, and as you said about the proton therapy centers have been open for 2 years. So how does proton therapy fit within the clinical practice here?
So unlike some centers, but very similar to University of Pennsylvania, we don't have specialized proton doctors. So because similar to Penn, this proton site or center is integrated with the rest of the radiation oncology department. So just down the hall, you've got 5 vaults that have linear accelerators. So it's not like you have to travel to a different setting to actually get proton therapy. So as a result of that, we have doctors who specialize in disease site. So for example, I treat hematologic malignancies. We have doctors who do mostly head and neck, other doctors who do mostly breast cancer or CNS or pediatrics. So when you see a patient, if you decide that you think they might need protons, you don't have to send them to another physician in your department, in another location. You yourself can say, I think this patient might benefit from protons. We do have an internal proton, essentially a tumor board, where weekly, if you think your patient may benefit from protons, you put it on the schedule. That patient is presented, and the clinical details are presented. They'll look at the imaging to see where the tumor is. And the great thing is we have everybody in the room or on Zoom, if they're not physically there, who really needs to be part of the conversation. And that includes the billing people, because that is a big part of whether a patient can actually get protons. But also other physicians who specialize in your site or other sites. We have physicists. We have the physicists who really are focused on proton delivery. So they really understand all the nuts and bolts of what it takes to get a proton case. We also have nurses, therapists, et cetera. So all these folks can together decide whether this particular patient is someone who really benefits from protons. And there have been times when we don't treat 100% of our patients with protons, or even refer 100% of our patients. I don't think that makes any sense. I mean, there's very specific, cases that really are going to get the most benefit. And when you have a limited resource, you want to be very judicious about who you end up treating with protons. And so, there are cases where we'll actually look at it, and then people will say, what, you probably could do as good a job or better with a VMAP plan. Maybe protons is not the best case. So I think we're very, pretty honest in our opinions. We're not trying to push protons for people who really don't, don't need protons for that particular case.
Well, I guess with the integration, proton becomes a tool in your toolbox. It's one more modalities that your physicians can choose.
No, that's exactly correct. I mean, we offer other modalities. We offer, brachytherapy. We offer stereotactic radiosurgery. So this is yet another, way of treating a given patient with a given cancer. And our doctors are not, leaning one way or the other for any reason other than what they think is actually best for that particular patient.
So what indications mostly do you treat here? What's the major benefits that you see for the
so we're still, we have been open 2 years, but we're still kind of growing in terms of our proton volume and really trying to figure out how to treat more patients. But from the very beginning, we felt that a clear indication is many pediatric patients. And the reason it's clear is because often you get a dosimetric advantage with protons versus photons. In kids who have not fully matured, who are prepubertal, if you treat bone, for instance, or certain organs, that you will get, hypoplasia. If you follow them long enough. We know this because we have, 100 years of experience of treating kids with Hodgkin's with, photon fields, where we know that, you'll cure a lot of those and you will see, visible defects in bone growth. So, for example, that's like a very clear indication. But, there are other things where, if you're craniospinal radiation, for instance, where a long time ago when I was a resident, our standard treatment was treating, the brain with lateral fields and then using a single posterior photon field, through the back without any ability at that time, because we didn't have IMRT, to really shape the beam. So basically you had this beam that just went straight through. So what's in the field? Well, heart, right? You're actually exposing the heart in a growing child to a significant dose of radiation, esophagus, bowel, and some of the gonads, right? So I mean, potentially ovaries. If you treat low enough, you could get scattered to the testes. So basically, these kids would have lots of side effects just from the spinal field. It's pretty clear cut. If you dosimetrically, you're just going to get a superior dose distribution. You can really stop so that you basically have no dose to the bowel or to any of the organs that lie past the spinal canal. So that's a very straightforward case where no one's really going to argue of course you should treat with protons. But there are other cases. In brain tumors in kids, you certainly dosimetrically are going to get less radiation dose to a large part of the brain if you use protons than even if you use a VMAT plan. VMAT plans are very good at conforming the dose, but it's coming at the expense of treating more volume. And so you may get a very low dose volume outside of what you're treating, distal, but in a young kid, that can be really devastating 30 years, 20 years later. Because again, from papers that have been written 20, 30 years ago in kids with ALL who get whole brain irradiation, a lot of them are cured. But then 20 years later, you've got an increased incidence of meningiomas, gliomas, skin tumors, all sorts of tumors that are in field that are clearly related to the radiation. So again, that's a case, if you have a small kid or a child, doesn't have to be small, but just someone who's growing, even a young adult, you really want to spare even low doses from covering a significant volume. So those are the very straightforward cases. So basically, we push for many pediatric cases, especially if they're definitive, to get protons, and that's actually not hard in terms of insurance approval. I mean, insurance companies understand this. But I would argue that young adults, so not even people who are continuing to grow, but literally will be around for 30, 40, 50 years, you're exposing them to unnecessary radiation to the brain. And they also have an increased risk of these various cancers. So I think those two groups early on, we were treating. But now we've really tried to expand our pool of patients. So we have women with breast cancer, especially left-sided breast cancer, where there's emerging evidence that if you treat the coronary vessels, not even to such extremely high doses, but what we would consider like, moderate doses. If you look long term, their incidence of coronary artery disease is increased. There's no question about it. And I think there's other techniques that are being used, but protons is one technique that you can use to really try to limit the amount of dose that you're getting to some of these structures. I treat hematological malignancies, patients with Hodgkin's disease who have a mediastinal mass. I mean, you can certainly spare using anterior fields. If the mass goes down inferiorly enough, you would end up treating some of the left ventricle or the heart. You can certainly spare some of that dose in patients who are getting adriamycin. So you absolutely want to try to minimize dose to the heart muscle. There are some GI cancers, gastrointestinal, that we're using protons on. Some pelvic tumors, adults with pelvic sarcomas, where you really can do a much better job in sparing dose to some of the structures, the normal structures in the pelvis. Some head neck tumors. So we really are trying to diversify, our portfolio of patients that we feel comfortable with treating with protons. Somewhat's the learning curve, because different sites actually require different approaches in terms of the beam angles, in terms of what you're trying to spare. And so after 2 years, I think we're feeling a lot more comfortable, and so we are treating some of these other sites.
Well, it's great to see that your focus has been pediatric, which we know that's the major benefits of proton therapy, and now that you're expanding. Are you also doing clinical trials? Are these patients part of clinical trials or registry?
Yeah, so we're actually not running our own clinical trials, because you need lots of patients to show anything. Right. So what we are doing is participating in some of the national trials. So there's several out there. The ones that we have enrolled patients on, there's a lung trial looking at photons versus protons. There's an esophagus trial. So we've definitely been enrolling patients on those two trials. We are participating on cooperative group trials.
And so what do you see the growth or the evolution of proton therapy in a clinical practice? You have something pretty unique here with protons. You also have an in-room diagnostic CT scanner that can provide you some very unique capabilities of being able to visualize, to adapt the dose. Where do you see all of that coming together to improve the radiation therapy treatment?
So I think defining populations that really are going to benefit from protons and really studying them and reporting on them and convincing insurance companies that these groups of patients, we shouldn't really be required to come up with comparison plans, that they should basically put them into their policy. So I think there's a lot of work, and I don't think we alone can do it. I mean, it's going to come from some of these randomized trials. I mean, if the cooperative group trial, the Bouchet trial on breast cancer, shows that there's a reduced incidence of cardiac disease in women who get protons versus photons, I mean, I think insurance companies will then not be arguing so much. They'll basically say, yeah, this makes sense. This is an indication for which we'll pay for protons. So we need to participate on some of those research endeavors to really make it clear, like, these groups absolutely benefit from protons. That's number one. Number two, I think we're not doing a lot of hypofractionation with protons, but the rest of the field is, of course, moving in that direction. Hypofractionating using CyberKnife or stereotactic. I mean, brain is a perfect example. I mean, people have Gamma Knife, or they have LINAC-based stereotactic radiosurgery, where we're using large fraction but fewer numbers of fractions. Sarcoma, for example. I mean, historically, we've treated sarcomas pre-op, to like 5 weeks of radiation treatments. Where we're located, we are actually very aware of the need to try to shorten treatments. And the reason is because, as I mentioned, we serve 5 states. And some of these states are very far from us, and it could literally take, 10 hours of driving to get here. If you want someone to relocate and be here for a month or longer, that's a hard sell. If you could somehow show that, like a 5-fraction regimen is comparable, it doesn't have to be superior, but if it's comparable, you could actually treat a lot of those patients. I mean, we've already seen this with, for example, outside of protons, with lung, right? Mm-hmm. So we now no longer treat the 70 gray in 7 weeks, which we did when I was a resident. We treat with 3 to 5 fractions, and that's something you can sell to patients, even if they live at a distance. Yeah, sure, I'll go to your center, and I'll plan on spending like a week and a half there. Mm-hmm. So we haven't really pushed that with protons so much, but I think that's a big opportunity, because with protons, you could also spare potentially, some of the normal tissues. So, we are actually, I've been talking to my faculty about potentially doing some more hypofractionated trials, and we will, if we can, certainly try to put patients who are eligible to get protons, if we can, actually, make that happen in terms of insurance. So I think that's another area of research, is really hypofractionation, using protons. And a third area, which is farther away, is flash radiation. And it's really this idea, for people who don't know what flash is, it's literally like in a flash, you're giving radiation. So instead of taking a few minutes to deliver a dose of radiation that you may have to repeat, every day for maybe weeks and weeks, giving a much higher dose in one session in maybe like 1/10 of a second or even shorter. And it may be more than one treatment. There may be several treatments, but again, it would be hypofractionated. It wouldn't be, 2 gray, 5 days a week for 5 weeks. It would be, a much higher dose, maybe every other day for a few fractions. It's at an experimental stage where people are really trying to define in mouse models, also in dogs and cats, what fractionation schemes work, where do we actually see some improvement in normal tissue toxicity. And then eventually, there are some trials that have been done or ongoing, but at some point in the next several years, we need to have some of these trials that we would love to participate on.
Yeah. It's certainly a continuation, so the same thought of hypofractionation, where you're just improving the treatment benefits in a shorter amount of fractions, right? Yeah. So what do you see the role of imaging in proton therapy?
Well, it's very important, and I think if you move to hypofractionation, it becomes even more important, because when you're treating, every day for 6 weeks, there's a little bit of a slot factor. If one day you have me off a little bit, hopefully the next year you'll get it, and over the course of many, many weeks, even if the patient's off a little bit one day, it'll sort of average out, and you'll get, what you want to treat to a reasonable dose. The more you hypofractionate, the more imperative it becomes that you absolutely hit the target, right. So as we move towards hypofractionation with protons and with photons, imaging becomes even more important. And that's actually one of the things with flash radiation that people have been discussing, is that if you're going to treat with a couple of very large fractions, you need to get it right. I mean, you really need to know what you're treating. So imaging is important, has always been important, but it's even more important as we move into some of these shorter regimens.
What has been your experience with the CT on rail? You have a unique system here set up. What has been your experience?
So if you don't use CT on rails, you have KV imaging, on the machines, which is very good for certain settings. But if you have a tumor where, it can change in size during, the course of treatment, KV imaging is not going to give you the information you need. All it tells you is the bones are where they were supposed to be. But if the tumor is shrinking, especially if you're using protons, because it's so sensitive to things like air gaps and what's around the tumor, you really need to know that. So in our center, we typically will do CT on rails at the beginning, and then how often we do it, we'll often do it every week, but we could do it even more frequently if it's a tumor where we're really concerned that it's actually shrinking. And then that all gets into the whole idea of adaptive replanting. So as you're doing the imaging, if you do see a change, you can use those data and not have to do another CT sim, but use the data that you acquired during your CT on rails and use it in your treatment planning system and see how did the dose change to the tumor. So it's absolutely critical as we're trying to explore some of these concepts.
Well, thank you, Dr. Maity, for this very delightful conversations, and I look forward to continuing working with you on bringing more and more proton therapy to many more patients.
Yeah,
thank you.
Absolutely. I thank you very much for having me, and I look forward to working very closely with Mevion.
Thanks.